Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Dr. Sarah Cole from Mercy Hospital, St. Louis, about the reality of residency, shaping tomorrow's family physician. Let's get started.
Dr. Dan, good to see you.
Good seeing you, Faisel.
And Dr. Sarah Cole, welcome. It's so great to have you on the show.
It's lovely to be here. Thank you so much for the invitation. I'm excited.
We've been looking forward to having this conversation with you. And over the years, Dr. Dan and I have spent a lot of time doing medical education with residency programs, but specifically around value-based care. And I remember the first time I went into a community-based, like a strong community-based family medicine residency program. And I just thought, oh my gosh. I mean, at the time, I don't even think there were only like maybe a couple dozen of them across the country. And now there's like over 100 of them. I mean, it's really exciting, the growth that's happening in the community-based family medicine residency programs. But still, the bulk of the programs are still the hospital, the traditional, hospital-based family medicine residency programs. I'd like to start off by saying, what can we do? Because there's a huge shortage. What can we do to strengthen both sides? We need the community-based programs to produce good family doctors who understand all the complications that can happen. And then we also need the hospital-based programs to have more of that continuity of care, more of the relationship, the trust earning first, and then the relationship building. What can we do to make both of these sides stronger?
That's a really, first of all, that's a really big question, but it's a really good one. So let me see if I can sort of break down a few components of that. So as you know, our country has a shortage of family physicians, right? And so not only are we seeing community programs grow, we're seeing every type of program grow. We've seen really an explosion of family medicine programs across the past 5 years. We've added, 150, 200 programs just in that time frame. And they are a variety of programs. Some of them are large academic urban centers. Others are community-based, particularly in some more rural or some of our smaller town areas. And you're right, we really do need both, right? We care, as family physicians, we care for a diverse range of people in diverse areas. And so we need those programs that are really focused on community outreach, on delivering innovative patient care models in a really boots on the ground, real world, practical kind of way. But what that's driven by is research. And so we still need those academic institutions who can be driving some practice-based research networks, who can be looking to see what are the innovative care delivery models that are really effective, and how can we deploy those in community centers. So how we go about growing both of those and doing that, wow, Faisel, that is going to require a lot of disruptive change across a lot of different settings, beginning with the way we train medical students, to the way we recruit residents, to the way residents work during training, and to how we prepare them for the job market. That's a lot, my friend.
It's interesting over time. I think peak family doctors, at least for U.S. grads going into family medicine occurred, in 1997 or something, and the numbers have gone down, but we've seen it in other areas, right? Then we started relying on osteopaths to fill, and I know you're an osteopathic physician, and so we relied on more osteopaths coming in, and that seems to be at the peak now, right, of the percent of osteopaths going into family medicine. And then we've relied on the international medical graduates. And even when you're looking at caring for the population, we've started relying on the advanced practice providers. But now the numbers of advanced practice providers going into primary care are starting to peak and go down. So how do we make it a career that people want to be part? The relationship that we are able to develop is so cool, but how do we do it without burning people out? It probably doesn't matter what piece of paper you have hanging on the wall, you can wind up getting burned out if we're not careful. And how do we make this so that people have access to those healing relationships?
In graduate medical education, we talk about how do we make family medicine look attractive to medical students, allopathic medical students, osteopathic medical students, and international medical graduates. I think, for a lot of our applicants, they bear an incredible amount of student loan debt. That's a real problem in our nation right now. And so family medicine can be perceived by medical students as less financially advantageous. And so if you're carrying $250,000, $500,000 in medical student debt, that can be it can be a deterrent to going into a field that you perceive will not allow you to pay off that student loan as quickly as you would be able to otherwise. The workload is a thorny issue as well. The current crew of applicants into family medicine is very plugged into social media. And so they see Dr. Glaucomflecken, for example, who has his parody of the family medicine doctor. And, his glasses are askew and his hair is, a mess and his tie is rumpled. And I understand what he's trying to do. He's trying to demonstrate that family doctors can feel overworked and really, held back by the paperwork and the administrative burden. But if you are a medical student and your medical school doesn't have a robust department of family medicine that can really connect you with the joyful work that family physicians can do, and that stereotypical portrayal is the only view of family medicine that you are seeing, that's not going to make you feel attracted to that field. And so I love Dr. Glaucomflecken. Unfortunately, I do wonder if he's doing a disservice to the primary care shortage with that parody. I would instead love to see a parody where it's the family doc who's always popping into those hospital meetings and say, I can do that. I can deliver that baby. I can do that joint injection. I can cast that fracture. And the point of frustration is the hospital administrator who says, no, we don't need you to do that. We have specialists for that. And that's where the friction is coming in. And so I do wonder, what are the things that we can do to help with alternate sources of funding for medical school for our students so we can alleviate some of that crippling debt and open up access to primary care spots, whether that be with loan repayment, whether that be with pay it forward tuition models. And then also, what can we do as family docs to really counter that impression that the only thing we do is paperwork? How can we highlight the family docs who are building those relational components with their patients, who derive joy from that continuity, joy from the procedures that we're doing? Maybe we need our own Dr. Glaucomflecken to get out there and do that.
Right, which again, a different form of media back when, I guess I'm showing my age, when I was growing up. Marcus Welby was on TV, and that was the prototypical family doctor who was having these relationships, but he would spend an entire hour working on many times one interesting case. And how do we get people time to do that work? But then part of it is how so often in the hospital-owned practices, the primary care is considered to be the loss leader, right? So they don't want to put the resources there. And to do this and do it well, you need to learn how to lead teams. And I've got to say, I know the program directors are working on that, but when the resources aren't there to hire the teams, how do we educate our residents about leadership development? I got to spend the day yesterday with a group of doctors working on a value-based care model, and there was a fairly young leader there, and he was telling me the story about when he had been working in fee-for-service. He was like a medical director or an associate chief medical officer for a smaller hospital, and he said, I was at one of these meetings and I was in the back of the room and they were talking about this. I was sort of the kid listening to the adults talking at the table. And I just stopped him and I said, how many people in that room had a panel of patients? And he said, well, I was the only one that had a panel of patients. And I'm like, okay, we got to figure out how that you're not sitting in the back of the room. We need you at the table talking about this, helping to steer this behemoth health system that we have so that our patients are getting the care we need. How do we help educate our residents to be able to do that?
First of all, Dr. Dan, I love something you said early in that question, because I firmly believe that if the healthcare system were led by family doctors, it would not be in the state that it is right now. Family doctors are the ones who understand everything. They understand how the hospital works. They understand how the clinic works. They understand the importance of collaborating with their colleagues. They've seen everything through training. And yet we're also kind of the nice guys, right? And so we tend to be humble people, and the joy that we get is from that relationship with our patients. And so it's not always natural to a lot of family doctors to envision themselves in that leadership role. And so what you're really asking is, how do we craft a vision of a family doctor as the leader of the healthcare team? And that's actually one of the new core outcomes from the American Board of Family Medicine is, as we move into competency-based medical education and thinking, what are really the skills that the emerging early career family physician is going to need? Leadership is one of them. And so one of those core outcomes is program directors are going to need to attest that a graduating resident is capable of being a leader of an interdisciplinary healthcare team. And so that's going to drive a lot of curricular change, I think, as program directors think, how can I do this creatively? The ABFM also has their new Health Administration and Leadership Management Certificate of Added Qualification. And so thinking, how can we be preparing our residents to eventually sit for that CAQ? And I think the board is doing a great job of sort of driving some of that change just with those two things. So that leaves the program directors, which is me and my colleagues, sitting with those curricular changes, right? Blessedly, the ACGME actually gave us some additional elective time with residents about 2 years ago with a major revision of the accreditation requirements. And so I think a lot of us are looking to see, how can we use some focused elective time to develop advocacy electives, leadership electives, policy electives, research electives, so that we can steer our residents into having some exposure there. But that's not enough. We really need to be modeling that for our residents. So that means getting the faculty into leadership positions in their hospitals, on the clinics, even with state organizations, and then bringing that resident along. And not just to one meeting, right? But to every meeting. So putting a resident on a hospital committee for 3 years so that they can see how that works. And you're right, when they're a first year, they're going to want to sit in the back, right? Because they don't know what's going on. But getting them to the point where as a third year, they feel empowered to be up front and say, well, that's not what I'm seeing in my clinic. And gosh, I'm thinking about interviewing with your hospital system, for a job next year. And so let me tell you how I think it could be done better. I think that's one really creative way to get residents involved in that leadership position. Another way is simply by offering a fellowship or an optional 4th year of training that emphasizes leadership and administrative skills. But yeah, I think the way to do it is to get family docs up there in the first place so residents can see how it's done.
This is why family doctors do so well in the outcomes-based world and the models that reward you for improving health outcomes. I'm working on some training right now around earning trust, and the team I'm working with is so focused on the doctor-patient relationship to be successful in these value-based care models, focus on the doctor-patient relationship. And I said, no, it's not just the one relationship. I think about when I was a resident, so I trained also family medicine, unopposed family medicine residency program in Columbus, Georgia. And I remember it wasn't just about the doctor-patient relationship. It was the relationship I had with the nurses and with the staff, especially in labor and delivery. But then also the doctor-to-doctor relationship, all the curbsiding we did. Most of the time we were on the right track, but to be able to just curbside someone and say, hey, I got this. Since we've gotten into the whole value-based care movement, I feel that we are the ones who are the most prepared. We value these 3 core relationships with, that you need to have if you want to help earn trust and be an influencer, be a nudger, especially if you want to transition away from our current sick care system, because we can do both. That we can address whatever the issue is that the patient is feeling in the moment, and then at the same time have the conversation. Well, what could we have done to prevent this from happening in the first place and not let it happen again? Are you feeling that with your residents?
Just in terms of their capacity to build those relationships?
With this generation, this is a generation of residents. They're in the value-based care world. They're seeing all the disruptors and all this fun stuff happening with value-based care, with the direct primary care movement. Are you seeing that the focus is still there, that the drive is still there to focus on these three core relationships?
Oh, absolutely. So, and again, I think that stems from what tends to attract a medical student to family medicine in the first place, right? So one of my favorite things to do actually is read applications in the electronic residency application system, right? That's how you know I was a born program director nerd, because really, who likes doing that, right? But I really enjoy reading hundreds of personal statements that really come down to what brings them joy is connecting with people, and whether that be with a patient's family member, or with a team member. So I close each encounter that I have with a resident in clinic after we, do our post-huddle and we run through who were the patients that you saw today. Do you have any questions for me? I close each encounter with this question: what brought you joy today? 75% of the time, it's an encounter that they had with a patient, and at least 25% of the time, it's that they really enjoyed working with a colleague. They said, my MA and I, we had a lot of fun today. Or the nurse really helped me out when they, grabbed this patient for me and gave this injection when I was running behind, and I just really appreciated that. And I brought them a Hershey's Kiss as a thank you. And the reason we can have so many of those different staff members around all comes back to population health, value-based care, and having that interdisciplinary team to support the physician as the captain of that team as they really steer care for the patient. So yeah, I think there's a lot of enthusiasm for that.
We're recording this, I guess, a week from maybe a few days ahead of the match. And I think everybody always remembers the match. I remember I had a close friend who I was a roommate with in medical school, and he was always playing jokes on me. And I was at another friend's house, and he called and said he was the chairman of the department that was my first choice. And I was like, this is a joke. And I started to say something. Of course, this was before caller ID and all that. And I got on the phone, and it truly was the chair of the department telling me how excited he was for me to come to his program. And I was like, that could have gone sideways so many ways that day. But this is an exciting time for students. It's an exciting time for us as a specialty as well. What do you expect to see in the match this year?
Again, exciting times in the match with the growth of new family medicine programs and with the growth of existing programs. We each year for the past 5 years, we're seeing a record number of positions that are offered in the match. And we're actually seeing a record number of applicants who are matching into family medicine. So I anticipate that is going to go up again this year.
Yeah, I'm excited about the experience that students and residents will have as more of this, the AI is getting integrated into the practices, the ambient listening. We're playing around a lot at City Block Health with chart prep, all the work that has to go in with our nurses for case conference. So there was so much work that we're collecting, and now with it's amazing how it's able to pull in all this information and just present it in such a beautiful package. I'm excited to see what all of this will do, because with the disruptive value-based care movements and all, they were mostly private, and so many students and residents didn't get the opportunity to, or maybe if they got some rotation experience, but like you said, with the heavy student loan debt, there wasn't loan forgiveness or loan repayment in a lot of these private companies that had these fun, innovative models. So I'm excited for for the students, the residents to be able to experience all this innovation that's coming? Have you been seeing the AI and the influence of that with the students and the residents?
Absolutely. And the residents are particularly passionate about this. So we also in my healthcare system have the generative AI, when there's an emergency room handoff, a summary of office notes since the last visit. We use Dex Copilot as our virtual AI scribe. And so the decision point we've had to make in the residency is, at what point do you offer that technology to a student or a resident? Because you don't want to hinder their own development of their critical thinking skills, right? And also, we need a resident to prove to us, or a learner to prove to us, that they are capable of generating a differential diagnosis, an assessment, a plan on their own. And so where we have left that is, we would like our first year residents to not be using too many of those technology tools initially as part of their assessment. But when they get to be a second year or a third year and their panel size is growing and they're beginning to mimic what they're going to be doing once they're out in postgraduate practice, it's really important to learn how to use those tools, use them effectively, use them ethically, so that they really can hit the ground running when they're in their own practice. And not just AI, but clinical informatics as well. So the other thing that we are training our residents on is, we've been talking about value-based care. And so our residents get regular feedback on what does their patient panel look like, what are their quality metrics, what percentage of their patients with diabetes have a hemoglobin A1C that is controlled, what's their readmission rate, et cetera. And, again, when you're a first year resident, you're still just trying to learn where the bathrooms are and is it okay to tell someone to take Tylenol, right? And so they get these reports and they're like, I don't know what this is. I don't know what to do with it. And it doesn't really feel relevant to me right now at the stage I'm at in my learning. And there's exceptions. But again, by the time you get to be a second year, a third year, and you're starting to connect those dots of, oh, this is a patient I haven't seen in a while. I notice their medication adherence is falling off. I can see that reflected in the A1C that they had done, when they sort of randomly went for their labs. This is somebody I should get in with my nurse or with the diabetic educator or with me. And, we can think about how we can manage these touch points just with this patient panel and metrics panel that you've given me. And so they get really excited to see that. It's like a light bulb kind of went on over their head. And they're excited about introducing this technology into their practice.
And I think it's great to do that. Again, I was talking to some doctors that are starting to work in one of the risk-based, value-based care models, and they were just talking about how difficult it is to look at all the numbers. This specific provider had been in it about 6 months. And I'm like, when I was 6 months in as a resident, it was pretty complicated to look at a metabolic panel too, right? But you got to where you didn't sweat, when, what do I do when the CO2 is a little bit off? You don't do a whole lot when the CO2 is a little bit off. But, it's which one of those labs do you need to worry about? Which ones do you not? But it becomes second nature. I think it can do that as well. But I'm glad to hear that your trainees are getting exposed to it, because otherwise you wind up in practice and all of a sudden you start seeing report cards and you're like, well, everybody's always told me I live in Lake Wobegon, I'm above average, and now you're telling me that everybody can't be above average every day. So that's good to hear that they're doing that and they're getting an opportunity to look at that.
Do you think that, before I used to think, okay, how do you think family medicine is going to evolve over the next 10 years, right? But things are moving so fast. It's over the last year or two, my God, especially the last couple of months. Are you seeing, have you felt a shift in the mindset of a family medicine resident applicant, or a difference in the skill set?
I don't know if there's been a shift in the difference of the skill set upon entrance into residency. And that's simply because, frankly, medical school curriculum, for the most part, there's some excellent notable exceptions, is still pretty stagnant, right? For the most part, the curriculum for medical school looks, especially the first 2 years, looks about the same as when the three of us went. What I am seeing is a real shift in the skill set from first year of residency into third year. I'll give an example. So when I was a medical student, I had dozens, not a lot of dozens, but a couple dozen deliveries to my name. Now, the attending was right there. They either had their hands on mine, or were right there in case something went wrong. But what that meant was when I headed into my first year labor and delivery rotation, I had a higher level of confidence in my ability to do that than a medical student nowadays who, quite frankly, most of whom are not going to be coming out of medical school having had a couple dozen deliveries, frankly. That's just not the way the curriculum is set up anymore with current levels of supervision. And there's a great deal of advantages to that in terms of patient safety. And then there's also some disadvantages from a learning curve. I think what that does to a certain degree is because that learning is shifted back, and we need to really emphasize those procedural skills in residency, it can make a difference in confidence, right? So if you're not sort of coming into your own in terms of confidence with, again, labor and delivery skills by second year or third year, that might influence what you look for in your postgraduate practice. I've had at least a couple residents at the end of their third year of training say, if I had a little more experience with this earlier in my medical educational journey, I might have chosen to incorporate skill XYZ into my postgraduate practice, and I might have looked for a completely different type of job when I was heading into practice. And some will backtrack and will then go look for a different job after a year or two, and some don't. Some then sort of find themselves in the job that they felt they were trained for when they were at the beginning of second year, instead of at the end of third year. And so that's one conundrum that we as program directors really kind of sit with, is with a little bit less hands-on experience during medical school, particularly with the influence of COVID, when medical students were really sort of yanked out of their third and fourth year rotations, is how do you compress that into a time frame so that we are graduating residents who really want to be doing the full breadth of family medicine in a way that brings them joy.
I remember the influence of a strong chief resident over the interns. If they had I remember having a chief resident who was really big with doing the procedures, learn the procedures, got to get the procedure, got to get out in the world and do procedures. And then the next year when somebody else came in and was saying, no, you got to know the procedures, but you got to do this work to help keep the patients from going to the emergency room. It's almost like in each residency program, there's like the influencer. So what advice would you give to, like, say, a resident first year, second year, to help them make sure that the training experience they have aligns with what they want to do when they, as they build what they want to build after they finish their residency?
So my number one piece of advice is self-reflection, right? That's one of the keystones of adult learning, is really discerning what brings you joy, what does your future community need from you, and then where are your weaknesses, right? Because we all have things that we're not as good at, and that's hard for us to admit at times. So I will oftentimes say, if there's something you are routinely shying away from, that might indicate it's something that you don't feel as confident in. That is an area to intentionally go bolster. And our residents will sit down every 6 months. They will make an individualized learning plan. And so we ask that one of their learning goals be something that brings them joy, something they're just really excited or passionate and they want to learn more about, something that they are going to need in their postgraduate practice. And that might even be, I need to go explore and see what type of practice do I want. Maybe it's going and spending some time with somebody in DPC, for example, or who's self-employed, to see if that's the type of model that they want moving forward. And then what's one area that they can sort of shore up so that they can really be that well-rounded physician when they go out. So my number one piece of advice is to do some self-reflection and see, what's the type of family doc you want to be and where are you at right now. And then my number two piece of advice is talk to your faculty, because they're the ones who can coach you through that. So they are the ones who have the resources. They've worked with residents already who probably had some of the same goals that you did. And so they can point you to the institutional or the community resources that are going to build that. They've got a great network of of subspecialists and other family docs who can help them.
Gosh, thank you so much, Dr. Cole, for taking the time out of your busy schedule to have this conversation with us. We wish you all the best with the match this year.
Thank you. I appreciate that.
What are your thoughts on the reality of residency shaping tomorrow's family physicians? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.